Okay. All right, Isha, you can launch.
Okay, yeah. Hi, hi everyone. We have around 91 participants, so I think we should start now. Good morning, everyone. On behalf of IFPRI, Niti Aayog, IIPS, UNICEF, and IEG, I welcome you all to this second webinar of the Nfhs 5 series that the first one that we hosted last year with the same title, but that was with just the phase 1 data of the Nfhs 5. So I welcome you all to this second webinar on Towards Progress on Nutrition in India, Insights from National Family Health Survey 5. And today we will talk about the trends, the data, what's the data saying, and have a discussion and launch the knowledge products based on the Nfhs 5 survey for both phase 1 and phase 2 districts. So quickly, before handing it over to Punnama, I would like to take all of you through the agenda for today. So as you can see, we will start with welcome and introductions, and Punnama will set the context on why we are here. Then we will hand it over to Dr. S.K. Singh, who's professor from IIPS, who will talk about strategies to ensure the quality of data in context of the pandemic. Then we'll go deep dive into the trends in nutrition outcomes and what are the learnings, nutrition outcome determinants and interventions between 2016 and 2021, that is Nfhs 4 and Nfhs 5. After that, we'll do a quick, we'll go through a snapshot of all the knowledge products that we are releasing. So we have 33 state nutrition profiles, 707 district nutrition profiles, and 1 data note on burden of undernutrition among children and women in India. After that, we'll hand it over to Dr. Rakesh Sarwal, who's the additional secretary from Niti Aayog, for his remarks on the use of products and further research questions of interest to support nutrition policy in India. And then we'll have remarks by a panelist. We have all the collaborating organizations, UNICEF, IEG, IIPS, and Niti Aayog as part of the panel. And we hope for a great discussion with the panelists and with all of you, because we have kept half an hour for Q&A and open discussion. So with this brief introduction, now I would like to introduce Dr. Punnama Menon and hand it over to her. So Dr. Menon is a senior research fellow at the International Food Policy Research Institute and is based in New Delhi. She's the theme leader for South Asia nutrition programs in IFPRI-POSHAN, that is Poverty, Health and Nutrition Division. In her work in India, she directs POSHAN, which stands for Partnership and Opportunities to Strengthen and Harmonize Actions for Nutrition in India, an initiative which is to support more use of evidence for nutrition in India. So over to you, Punnama, and let's begin.
Wonderful. Thank you so much, Isha, for that introduction. And thank you so much, colleagues, for joining us online today. I'd like to really offer a special thank you to the many partners who are with us and who have been working with us on designing, developing, and launching these knowledge products today. We stand at a really, at a point where we have 8 years left to achieve the global goals that countries came together to set out for ourselves on nutrition, on gender, on equality, on the 17 Sustainable Development Goals. We've made a lot of progress as a global community. We've made a lot of progress as a national community in discussing these goals and trying to understand what they mean in crafting policies and in crafting strategies. But the time now that lies ahead is a time for action, because we're only 8 years away from 2030. In a few years from now, we're going to begin to ask questions and begin to start to measure how countries have done on progress towards these development goals. As many of you know, nutrition has been an area of challenge for the South Asia region, and indeed an area of challenge for India as a country and for many states within India. At the same time, what we have seen over the last many years that we have been looking at and trying to understand the state of play of nutrition in countries like India is that what we're seeing is areas of progress, areas of stagnation, really a mixed picture. But what we also see is that we still bear, and India in particular, bears a tremendous responsibility, in a sense, for the world to achieve sustainable development goals, because the largest burden of malnutrition in almost any form lies in India, given the large population of India. So, as we sit at this very sort of pivotal moment where we have data that has come through to the community in India and really to the global community, this is an amazing time to sit and sort of reflect on, what change has happened, what challenges remain ahead of us, how large those challenges are, and where those challenges are located. Because I think what we have understood over time, and of course one knew this, but the kind of data that we have at hand, especially from India now, from so many districts across the country, is that despite global commitments, despite national strategies and commitments, despite state level, policies and programs and investments, the change that has to happen and the impact that has to come together will only happen if change happens on the ground for people. And that means that there is a great need to understand the state of play of malnutrition as it affects people on the ground. And we have a tremendous opportunity here with the incredible data set that is the National Family Health Survey in India, really the largest data set probably on, the largest data set in the DHS, the Demographic and Health Surveys family, certainly, and representative all the way down to the district level, which, as many of us know, is a really important administrative unit in India. Our team has been working with the data for many years now. We have worked with many of you as partners. And today is, really for me a real milestone, because we have come together with IFPRI-POSHAN, the group that has done the DHS, with Niti Aayog, a group that has been sort of really outlining strategy and actions for India and monitoring progress on India's national nutrition mission, with UNICEF, who have been supporting states and the policy community at large in India, and with IEG, who have been, also working with the nutrition data and especially around the anemia program, but more broadly as well. So it is, it's a milestone moment for all of us, in a sense, to be able to put out this joint series of products that enable us to take a view of the nutrition challenge. So I don't want to get in the way of of you, the audience, and hearing about the work that we have put together. I just want to end, in a sense, before I hand over to back to Isha to introduce the remaining speakers and launch the program. To really just reflect on the fact that data and knowledge is not an end in and of itself. The data products that you see here, the knowledge and the insights that are gained from the data are a means to an end. And by putting these things together, by framing them the way that we have framed them, we really hope that this gives everyone who's interested in solving the problems of malnutrition a way of understanding the challenge, of understanding, as I mentioned earlier, how large the challenge is in different parts of this country. And I would love for everyone to really think about these things as a means to an end, a real opportunity to reflect, to understand, and to inform action. It would be really inadequate for all of us if all we did was, have these products up on the web for, and not invest in using them as we look forward. So with that, let me hand it back to you, Isha. And again, thank you all very much for joining us today at this event and online. Isha, back to you.
Thank you. Thank you, Punnama. So now I would like to introduce Dr. S.K. Singh, who will be talking about strategies to ensure the quality of nutrition data in the context of the pandemic. Dr. S.K. Singh is Professor, Department of Mathematical Demography and Statistics, International Institute for Population Sciences. His major research assignments completed in the last 1 decade includes National Family Health Survey, Nfhs in India, and district-level household and facility survey. Over to you, Dr. Singh, and you have 10 minutes.
Thank you, Isha. Thanks, Punnama. Good morning to all the panelists and all members who are attending this important webinar on progress of Poshan Abhiyan in this country, evidence from key findings emerging from two phases of National Family Health Survey. I would like to share my presentation. As she has mentioned, I'm presenting here on quality of data. What is our strategy in a National Family Health Survey to ensure the quality of nutrition data in the country? Because all of us are knowing that we started Nfhs 5 sometimes in June 2019, and just when we completed our first phase of the survey, subsequently country faced the problem of COVID-19 that resulted into halting of the data collection process for around 9 months. And after that, we developed a standard operating procedure. I want to share with you how our standard operating procedures, along with various other innovations to ensure data quality with increasing use of artificial intelligence and machine learning techniques, has provided us opportunity to provide good quality data, including our nutrition data, because in case of nutrition, both anthropometric as well as blood sample collection for anemia requires just physical contact with our interviewer and respondents. That was the real crux of the issue, where everyone was apprehensive. And I want to show you the evidence that whatever strategy we have adopted, that's quite satisfactory to ensure quality of data. These are the 5 issues around which I have organized my presentation. There is no need of highlighting this issue because everyone is knowing that whenever we are starting any survey, whether it is demographic, health, or development related issues, we are ensuring our quality consideration is starting from framing of new questions or adding any new questions. That is why even in Nfhs 5 also we have adopted those policy. We don't leave any scope for ambiguity in canvassing on questionnaires, and also all new questions are tested for cognitive testing for comprehension and retrieval of respondents, which also are helpful in maintaining our overall response rate. That is why we are in a position to look for one of the important intervention before the country, that's Poshan Abhiyan. All of you might have already heard at one or other forum that how Nfhs adopt multiple strategies to ensure validity and reliability of our estimates. Start from sampling design, framing questions, training of investigators, to standardization of survey implementation protocols, along with constant innovations to strengthen data ecosystem in the country. That's applicable even. These are the core strategies. Since these strategies are specific to overall Nfhs, nutrition data, health data, development indicator, demographic indicator, I'm not going to highlight those. I suspect that most of the participants in this webinar might have definitely come across our multiple strategies which we have innovated from Nfhs 1 to Nfhs 5. That is very well. But definitely I would like to talk about 3 important things. How real-time access of data using field check tables, which is possible with increasing use of artificial intelligence techniques, which provides an opportunity for real-time access of data and providing immediate feedback if there is any deviance, either in terms of our height measurement, weight measurement, or any other indicators, providing us opportunity to look at nutrition data. We are also using here generating error message. Error message and POQR are the 2 new artificial intelligence based applications which Nfhs 5 has adopted, that has helped us irrespective of pandemic situation. These innovations we did even in first phase also. Now in Nfhs 6 we are going to adopt 3 more new innovations which I am pretty sure will be further strengthening quality of data, quality of our nutrition data also. Why? Yeah. Yeah, all of you might be, all the participants may be aware that Nfhs, whether it's our paper pencil questionnaire to departure from paper pencil to KP based data collection, has been providing a lot of opportunities to minimize various kind of errors in data collections, including skip patterns, following skip pattern, or intentional skip patterns, intentional skipping of certain questions in age displacement, birth displacement. These are some of the important issues which are ultimately affecting our quality of data. And that is why whatever is the possibility, we are taking care of all that while looking at our data. This is about, I was talking about generating error message and field editing. That I have already explained how our KP program is helping that. And once we are completing data collection using KP program in a particular PSU, supervisor is assigned the responsibility to run this error message. And wherever there is any inconsistency, those inconsistency we are correcting even before leaving the PSU. These are some of the examples which I don't want to elaborate. Second application is talking about our this POQR, which right has been given to our monitoring team. That is our project officers appointed by IIPS. They are given a specific login and password. Only they can use those login and password to check the data on daily basis, which are coming in a particular district, irrespective of number of teams working in the district. And these field check tables are providing us opportunity. On every day evening, our quality assurance team at IIPS is looking whether survey is being conducted in Kashmir or it's Kanyakumari or Kutch, Gujarat to Arunachal Pradesh, Tawang area. But sitting at IIPS, we are able to have a real-time access of data along with the graphical presentation. All of us are having the access even on our smartphone. No need of central server, no need of central office data. When we face the pandemic situation after completing first phase, we immediately developed one standard operating procedure in a pandemic situation that has around 6 to 7 components. Starting from insurance coverage, all core team members were mandated to Arogya Setu. That was not new for Nfhs, that was true everywhere. But here, our team members were advised to eat or drink alone or proper social distancing. Physical distancing was instructed to maintain during interview, ensuring privacy and confidentiality. Teams were educated to check the well-being of each team member every morning before leaving to the field and doing thermal screening for all team members. After reaching to community, we started our standard operating procedure, develop a mechanism to first interact with the community people, discuss with them about 22 households where our team was supposed to go there, find out whether there is any member suspected cases of COVID-19 or not, thermal screening of community people who are willing at mass level, providing masks, sanitizer, and COVID-19 brochure to all the selected households. Each respondent was instructed to give a new mask during interview and cave investigation, compulsory thermal screening of all members of selected households, and cave investigation were conducted with minimum contact with the respondents. These are some of the process indicators. If you compare, left side table talks about pre-pandemic situation, right side is talking about post-pandemic situation. If you look at response rate, absolutely, let us talk about the post-pandemic situation. This is standard operating procedure. I am not presenting before you the causal linkages, which activity through what pathway has influenced, but I am basically talking about output indicators. It cannot be outcome indicators. I will share with you. Here, even if you look at Arunachal Pradesh, our household completion rate was increased from 86% to 96%. And in most of the states, only Punjab was the exception, where there was slight decline. Tamil Nadu also, but those declines cannot be considered as a significant. Only Punjab, it's 6% point, which was a dual problem of COVID as well as farmers' education at the time of survey. That is why there is slightly lower response rate. Even in case of women also, we are able to maintain response rate. And if you look at weight and height measurement, where there is a chance of physical contact, unless until a health investigator is not having physical contact, they cannot do height and weight measurement. They cannot blood sample. Even in those indicators also, not only in first phase of Nfhs, which was conducted in pre-COVID situation, even in post-pandemic situation also. Haryana has gone slightly down, but those differences are not significant. Remaining all states, we have been able to maintain our response rate in completion rate of weight measurement. Delhi, it has even improved also. Similar situation is there in even height measurement also. Height measurement of women, if you are looking. Again, Delhi, we have improved, and Haryana is showing slight deviation. In first phase, there was Bihar slight decline, and Sikkim also, there was a minor decline. Otherwise, by and large, we are able to maintain. That indicates, even I am not presenting those results, but even completion of our date of birth, which is also one of the important parameters when we are looking at quality of nutrition data. If we are coming in case of children, we are getting a similar situation. Similar situation, whatever we have got in case of completion of weight measurement among children. First phase, most of the states except Gujarat and Meghalaya, Gujarat, Meghalaya and Nagaland, it has gone up. Even in post-pandemic situation, we have, except Haryana, here, except Haryana, in the rest of the states, we have been able to, both height and weight, both the measurements we are able to. If you look at anemia, collecting blood sample in case of anemia, here also we are getting definitely, in some of the states in post-pandemic situation, there has been some decline, but the decline is not very profound. If you look at NCT Delhi, it has increased from 78% to 90%. Even in case of Arunachal Pradesh, it has increased significantly. Chhattisgarh increased. Haryana slight decline. Jharkhand from 99% to 95%. I am pretty sure that is not going to affect us badly. We are able to maintain.
Dr. Singh, apologies. I would request you to kindly wrap up in another minute.
Yeah, if you look at child anemia, in case of children also we are able to. Now look in terms of quality, how is our stunting, wasting and underweight. This kernel density curve, along with all the 4 parameters, are within range. There is no significant deviance in case of distribution of kernel density estimates of Hmis scores. A similar situation we are getting in case of wasting also, and we are getting even underweight also. That is why all these parameters, if you compare from Nfhs 2, 3, 4, and 5, if we are comparing pre-COVID and post-COVID scenario, there is not much deviance. We are in a better position. If you look at the Icds coverage, which people have generally believed that Icds services has been halted, that is why it is highly underutilized. If we are claiming that in 12 states in the country, there is a significant improvement in various, almost all nutrition indicators, 12 states. Remaining, there is insignificant variation. You can get evidence as soon as we are releasing the data in public domain. Probably on 26th of April, we are likely to release that, if minister is able to release the report as per the timeline. But I am sharing with you here, which is of course based on like kernel density curve. It is also based on that. Not only in first phase states, even in post-pandemic situation, but only thing is that my indicator is slightly weak. Any use of Icds, that is for health checkup also, that weight measurement also, supplementary food also. Detail we will work out later on. But there is one emerging challenge here. If you look at stunting, anemia, and overweight, wherever there is stunting is lower, they are still suffering with the problem of high anemia. At the same time, higher prevalence of overweight is going to be a real challenge. That is why in our nutrition program, we should not only focus at undernutrition. Overnutrition is also emerging as a significant problem. On micro level analysis, we will find that this problem is primarily in 10 states where urban children are just increasing the overall prevalence. With this, I am concluding my presentation that Nfhs has been striving continuously increasing quality insurance mechanism, including SOPs for a pandemic situation. And my last conclusion is that no significant deviance in data quality or quality of nutrition data or various measures of undernutrition and overnutrition, even in the pandemic situation. Thank you. Thanks a lot.
Thank you, Dr. Singh. Thank you for the detailed presentation. And I request all the participants to kindly post any comments in the chat box and any questions in the Q&A box. And we will try to take up all the questions towards the end of the webinar. Moving forward, now I would like to introduce Dr. Phuong Nguyen. Dr. Phuong is a Senior Research Fellow at Poverty, Health and Nutrition Division at the International Food Policy Research Institute. Her research interests are in the area of maternal and child health and nutrition. Currently, Dr. Nguyen is the team leader of the Data and Evidence to Support Policy Implementation component for the POSHAN project. Over to you, Phuong.
Thank you, Isha. So let me share the screen. Please let me know if my screen is visible.
It is visible, Phuong.
Thank you. Okay. So on behalf of the data team at POSHAN, I would like to present a few snapshots on trend in nutrition outcome, determinant and intervention between the two survey rounds, Nfhs 4 and 5. So basically on this presentation, we want to show some initial analysis on both outcome determinant and intervention at national and subnational level. We look at the trend, we're ranking the state for the worst and the best performing state. We also look at the head count burden to find out the highest burden state. And then we also rank the district with some public health concern. So mainly we use the data source for two rounds of Nfhs 4 and 5. And for the trend, we look at the 575 district comparable across the two rounds. We use the bar graph to show the national trend and the COMEX plot to show the state level of trend. For the district level, we use visualization by map. And then we use the census data from 2011 to project the current data for children less than 5 years, women and men. And then for pregnant women and lactating women, we use a number from Hmis data. And then we calculate the burden for outcome, for determinant, and for coverage at the state and then also at the district level. So we select several indicators at different levels. Just example for outcome, we look at both undernutrition and overweight, obesity, and NCD. And for each of the outcome, we also look at 7 states of life. Just example for children less than 5 years, for non-pregnant women and for pregnant women. Here we look at both anthropometry and an anemia data. For overweight and NCD, we look at overweight, obesity in women, in children, in men. For the sake of the presentation today, because of limited time, we more focus on undernutrition and also look at the determinant of undernutrition at different levels. Just example, we look at the immediate determinant, the underlying determinant, and about 30 health and nutrition intervention that can have some association with the outcomes. So just example here, for the trend in undernutrition outcome at national level, we can see that for most of indicators related to anthropometry like stunting, wasting, underweight among children, and underweight among women, we see there's a positive pattern of reduction over time between Nfhs 4 and 5. But for anemia, we can see that it have a pattern of increase in both children, in non-anemic, in non-pregnant women and in pregnant women. And the prevalence is really high, more than 50% among women and even 67% in children. So that is worrisome for the anemia among children and women. Look at just example for each indicator. We look at the trend by different states. So just example here, we look at trend on stunting, and you can see that the green one shows that the improvement over time, but the red one shows that it have worsened. That means the stunting increase over time for the state with the red line here. So in this one, we can see that among 34 states, we can see that 12 states have the trend of increase over time, that means worsen, but luckily we have a 22 state with the green one, that means it have improved over time. And the improvement is a large for Bihar, for Jharkhand, for MP, for Rajasthan, and also for UP. So we see a lot of good pattern here at the state level. And then we also calculate the number of burden of stunting by state. And then we can see clearly here that UP account for the most burden of stunting with more than 10 million of children stunted. Bihar followed that with more than 6,000, and then 6 million. And then we can also see with other states, like the burden of stunting in other states, how it looked like. Then we also look at how the stunting prevalence at the district level change over time. Here we use a map, use a cutoff by WHO with the very red one, a dark red one, so that very severe public health problem with more than 40%. The red one is a high prevalence between 30 and 40. And then the one with the yellow is low, it's 10 or 20%, and if there's green, it would be less than 10% of stunting. So we can see in the map here that over time, no district in India have a less than 10% of stunting. There's few states with a 10 to 20%, but over time, we can see that the red dot here have a less in 2021. That means several of districts have moved to a better, less public health problem with the stunting. And we also use this data to rank the district with the highest prevalent district. Here we can see that several districts in UP and Bihar and in Jharkhand have very high prevalence with more than 50% of stunting prevalence. So basically, based on this, we also look at the map for several other indicators, but in the interest of time, I only show stunting. So if we look at here, we can have summarized that at the national level, we can see the improvement with the green here for stunting, for wasting, for underweight children, for underweight women. But we have a little bit increase in severe wasting and an anemia among children and pregnant women. We can see that what is the worst performance state? That means the ones that have an increase in stunting or wasting or other prevalent, or what is the best performing with a good reduction in different underlying different indicator of undernutrition. Then we can also see that what is the state with the highest burden of different things. And here we can see that UP and Bihar show up with several indicators because the population is also high in that state. And then finally, we show the percent of district with the public health concern. And here the worrisome is more than 80% of the district have a public health concern for different indicator of undernutrition or anemia. So we also look at the determinant of undernutrition. As example, here we can see that in the immediate determinant, we see a good pattern of increase, reduce underweight among women, increase the consumption of IFA, increase several indicators of infant and young child feeding practice. But the worrisome here is the number percent of children with adequate diet. Even it have a slightly increase, only about 11% of children with adequate diet. And with women consume 100 tablet of IFA, only less than half of the women. So it's still a lot of room for improvement here. So similar to the other one, we also look at how it vary by the state. Just example here is a exclusive breastfeeding. The good news is we see a lot of improvement with the green one here, but there's few states have some worry. Just example, Sikkim reduce a lot of EBF, or Tripura have a lot of reduction in EBF here. Here we also look at the number who are not exclusively breastfeed. So we can see the burden in different states here. And again, we make the graph for the map for the district level to show like how prevalence of exclusive breastfeeding change over time for different district, and see what is the public health problem and ranking the district with the lowest prevalence of exclusive breastfeeding. We do the same for all the underlying other immediate determinants. So again, we also have a table to summarize. We can look at here like most of the immediate determinant improve over time. What is the best performing, what is the not best performing state, and what is a high burden here. So I will not go through that very carefully. Then in the underlying determinant, we can see here that we see several underlying determinants have a good percentage. That means it have a good performance over time and improve over time. Particularly the household with improved sanitation, it improved from 48 to 70%. A little bit worrisome here is the indicator related to woman gender. Just example, women with more than 10 years of education, it improved nearly 4 percentage points, but only 41% of women with 10 years of education. And the girl married before the 18 still account for nearly a quarter of the population here. There's few other indicators related to sanitation or urbanification. We don't have data yet. We are currently working at IFPRI-POSHAN to fill in the gap of this one. This example here, we also look at how the state change in women education. And then we can see here that the education among women improved in almost every state except for Tripura. We also look at the burden, like how many women who are not get at least 10 education. And then we can see how the burden different in different states. And then we see how the parent change over time for different districts. And then the 20 district with the lowest prevalence of women with more than 10 education. So we can see it here with the ranking, and then we can prioritize the thing for the district. So again, we have summary of underlying determinant, and we see most of pattern have a show improvement over time, and we see the worst performing those states. So I didn't go too detail on this one. Finally, we look at coverage of nutrition intervention. And here we have about 30 interventions across different states applied during pregnancy, delivery, postnatal, and early childhood. We can see here we still have some missing data because currently we are still working with IFPRI to fill in this gap. But for those who are with available data, we can see that there's a good tendency of improve the indicator of the intervention across 1,000 days, with most of them that the value of 19 is higher than the 16. And we just saw one example here with ANC4 that is still worrisome, that if we can see that several states with the green one that show improvement in ANC, but still have several states so that the ANC4 reduce over time. And there's several, here it shows the number of women who are not covered by ANC4 visit. Again, we also show the map. And then the good news here is several states, the district come from the dark red here to come less dark. That means it has some improvement. So again, we also summarize all the intervention to see how it improved over time. Which state we perform the best, not good, and then what is a high burden in different states, and then what is the percent of district with low coverage here. So in summary, we can see that for outcome, most of undernutrition outcome related to anthropometry have reduction. That means good improvement over time. But anemia in children and women still worrisome with the increase between 2 to 9 percentage point, and then the prevalence is still more than 50%. The immediate determinant have improved most for IYCF indicator, but adequate diet still low and IFA consumption among women still low. Underlying determinant also have a large improvement in sanitation, but some indicator related to women and education and early marriage still worrisome and need lots of attention. Most of intervention have a more than 50% of coverage, but for ANC and zinc during diarrhea still remain low. We can see that among more than 80% of comparable districts, all the forms of undernutrition are still public health concern based on WHO indicator. And there's a large variability in prevalence over time by state and by district level. And the burden of undernutrition and low prevalence of other determinants is in the largest state, mainly in UP and followed by Bihar. So we have about more than 100 slides for different trends in outcome determinant. So we will encourage you to look at the full slide that we will show later and we can share later. And besides the state presentation, we also have the state nutrition profile, state presentation, and the district nutrition profile, and data on topical issues that my colleagues will talk in the next few minutes. Thank you.
I encourage all of you to please keep posting your question in the Q&A box, and we will try to take up as many as questions as we can towards the end of the webinar. And for all those who are asking, yes, all the presentations will be uploaded on our website, and the recording of this webinar will be on YouTube, and the links will be shared with all of you who have registered for the webinar. So as Fung mentioned, now I would like to invite IFPRI research analysts Anjali Pant, Nishmeet Singh, and Soira Gune, who will take us through the state nutrition profiles, district nutrition profiles, and the topical data node on 100 high burden districts that we are launching today. So I hand it over to Anjali to start with the state nutrition profile, followed by Nishmeet, and then Soira with the 100 high burden districts on undernutrition. So over to you, Anjali.
Thank you, Isha. Just give me a minute and I'll share my screen. Let me know if my screen is visible to you.
It's visible, Anjali.
Okay, thank you. So hello, everyone. I'm very delighted to share with you that IFPRI, in collaboration with Niti Aayog, IFPS, UNICEF, and IG, is launching 33 state nutrition profiles today. These profiles provide insights on nutrition outcomes, determinants, and interventions for the time periods 2006, 16, and 21 at state and district levels. It specifically looks into trends in the indicators over time. It looks into burden of nutrition indicators, for example, number of children stunted. Third, it looks into the priority districts, that is the worst and the best performing districts in a state, the high coverage and the high burden districts, and districts with public health concern. And it includes a summary where the nutrition status of a state is briefly discussed and the areas of improvement are identified. These profiles are short, straightforward, yet informative, with lots of different visuals, detailed footnotes, and a glossary. These profiles are primarily based on the National Family Health Survey 345 fact sheet and reports. We have also used Census 2011 and HMIS 2019 to compute the burden. These profiles have been prepared to disseminate knowledge, facilitate discussions, and more research in nutrition domain, and to inform policy decisions to benefit the society at large. These profiles can be used by multiple stakeholders ranging from policymakers, implementation officers, researchers, funding agencies, and even students pursuing nutrition-specific master's program. We have discussed 77 indicators in the state nutrition profiles covering 16 outcomes, 25 determinants, and 36 nutrition-specific interventions. These indicators were primarily selected based on the POSHAN Abhiyan monitoring framework. Indicator availability in the Nfhs 5 fact sheets and report, and comparability of these indicators across the survey rounds were also some of the other important selection criteria. Now I'll walk you through some of the unique components of these state nutrition profiles. So here, as you can see, the undernutrition trends have been illustrated using bar graphs for the time periods 2006, 16, and 21. And in each of these SNPs, there are footnotes where details pertaining to the data source, indicator creation, data unavailability, etc. have been discussed. Burden of undernutrition at district level has been illustrated using spatial maps. Top 5 highest burden districts and number of districts with public health concern have also been listed. This output is available for all the undernutrition outcomes that are covered in the state nutrition profiles. In the overweight and NCDs page, trends at state level have been illustrated using bar graphs. In addition to this, worst and best performing districts, highest burden districts, and districts with public health concern have also been identified for each of these outcomes. In the immediate determinants page, trends at state level have been illustrated using the rounded bar charts. In addition to this, worst and best performing districts and the top coverage districts have also been identified. Similar analysis has been done for underlying determinants and interventions as well, and that is available in the state nutrition profile, but in the interest of time, I'll not present the output in today's discussion. Intervention coverage at state and district level is illustrated using a color-coded dashboard for the year 2019-21. Prevalence has been classified into 5 buckets and color-coded accordingly, where maroon color depicts least coverage and green color depicts largest coverage. The SNP ends with a brief yet informative summary where key findings are discussed as well as the areas of improvement are suggested. And towards the end of the product, there is a detailed glossary to help the user to understand the definition of the indicators, how they were constructed, and the data source that was used. So similar to the state nutrition profiles, there are very detailed district nutrition profiles that our team have prepared. And I would like to invite Nishmeet Singh, my colleague, to share the details of this product. So Nishmeet, over to you now.
Thank you, Anjali. So thank you, Anjali, for presenting the state nutrition profiles. I'm not going to talk about the district nutrition profiles. So as Anjali mentioned, and Fungus also presented the national trends, I'm going to talk about the district nutrition profiles, which basically give us a sense of what's happening at the district level. And this series is a step to bridge knowledge at the district level. So IFPRI-POSHAN, again, with generous participation from partners and collaborators, has generated these district nutrition profiles for 707 districts of India, with the aim of creating awareness, facilitating evidence-based discussions, and mobilizing nutrition actions for nutrition at the district level. So these district nutrition profiles are basically 4-page profiles which present a snapshot of the state of nutrition and its multiple determinants in each district. These district nutrition profiles, or DNPs as we call it, were first launched by the IFPRI-POSHAN team in 2017 using data from the Nfhs 4 round. And now we're going to launch the district nutrition profiles for 2020 with the aim to understand trends in nutrition indicators using Nfhs 4 and Nfhs 5 data. So the district nutrition profiles have been conceptualized based on the UNICEF framework that was developed in 1990 and then modified by Black and others in a 2008 paper that lays out the causes of nutrition at 3 levels: intermediate, underlying, and basic. And this framework, again, has been further adapted to demonstrate the role of interventions targeting specific, again, sets of determinants, in bringing optimal fetal and child nutrition and development, basically. So what we do is, these profiles are very easy to read with very few technical terms and an abundance of infographics to sort of facilitate understanding among diverse stakeholders working in nutrition. Next slide, please, Anjali. So they feature basically data when available on 71 actionable indicators that cover the range of nutritional determinants and outcomes. As you can see, we have a short demographic profile of the district, including number of live births, pregnant women, children, And then we have like the state of nutrition in terms of outcomes of undernutrition as well as overnutrition, especially those related to maternal side of overnutrition. And then we have indicators on immediate and underlying determinants, as well as followed by the coverage of nutrition specific interventions. And just to mention the criteria for selection of indicators, I remember when we started sort of mapping these indicators, we had over sort of 200 indicators that we have mapped up across across board that were sort of topical priority, again, alignment with the POSHAN framework, as well as global references for determinants. But then we narrowed it down to applicability, based on applicability to a general population, then need to monitor progress. And this was done all collaboratively with the partners that have been mentioned, IAG, IIPS, UNICEF, DataDent again. So all these partners, collaborators came together and we narrowed it down to these 71 actionable indicators. Again, the last criteria, of course, would be availability of data, what's available in Nfhs 4, 5, and some figures that you could take from the HMIS stuff as well. Okay, next slide, please. So here you see a quick snapshot that we have 707 profiles that are available, 775 for districts that are comparable between Nfhs 4 and Nfhs 5. As many of us would know, that the Nfhs 4 had data for around 640 districts, but the Nfhs 5 now has 707 profiles, but only 775 of them have comparable data. So we have the comparable version, which shows the trends in undernutrition, but we also have the 132 for non-comparable districts, which shows a single data point, and that can be also useful. And you can also see on the right that we've kept some points of discussion for people who are looking at these profiles and looking at the outcomes, and these are on all pages. So if you look at outcome trends, determinant trends, as well as coverage trends, we've given a few points that you could think about when you look at these numbers. And we've also given the burden numbers also on the right in the table. Next, please. Again, so this is the third page of the DNPs, where we see immediate and underlying determinants. We have, again, from feeding practices to exposure to diseases in the first year of child's life, IYCF indicators, disease burden indicators. We've tried to cover as much as possible within this quick snapshot, so that it's useful for people who are looking at this and they get a quick snapshot of what's happening in their districts, or researchers who want to look at a particular district and work in a particular district. They're useful for them as well. Next slide, please. And finally, we gave a snapshot of the coverage indicators, nutrition specific interventions that look at again divided by prenatal and delivery care, then postnatal and early childhood. So tracks of provision for services to women in the district from the time of registration of pregnancy until post-delivery, then moving on to early childhood, where we look at checkups and visits from health functionaries, financial assistance available, supplements and immunization. So we've tried to sort of give you a whole summary from outcomes to sort of coverage of intervention, so that you get a quick snapshot of what's happening at the district. So these are the district nutrition profiles, and I would encourage everyone to look at them. We have 707 profiles that will be available. So of your interest, whichever district you're interested in or whichever state you're interested in, you can look at that. Yeah, so that's the district nutrition profiles. And now I'll hand it over to my colleague Soira, who will give you a quick snapshot again of the data note. This is a topical data note on top 100 districts of undernutrition among children and women. So over to you, Soira.
Thank you, Anjali and Nishmeet. As Nishmeet mentioned, today I'm going to be presenting a brief snapshot on the data note on the top 100 districts of undernutrition among children and women. Next slide, please. The data note provides the top 100 districts with the highest burden for key undernutrition outcomes, which have been selected using the POSHAN Abhiyan monitoring framework. It is important to look at burden of undernutrition alongside prevalence while prioritizing districts, because addressing undernutrition in high burden districts has implications for undernutrition at both the state and the national level. And furthermore, the district level of POSHAN Abhiyan, the district level focus of POSHAN Abhiyan and certain World Health Assembly targets or SDG targets of undernutrition requiring reduction in burden makes this an important exercise to undertake. Briefly, the data note provides national and state level trends in prevalence for key undernutrition outcomes between Nfhs 4 and 5, namely stunting, wasting, severe wasting, underweight in children, and anemia among children and women of reproductive age. Additionally, the data note contains maps which illustrate state level burden of undernutrition using Nfhs 5 data. For 575 comparable districts between Nfhs 4 and 5, the data note visualizes district level burden through maps and provides tables and maps to highlight the top 100 districts with undernutrition burden for each undernutrition outcome. Data for prevalence estimates for Nfhs 4 and 5 are taken from the Nfhs 5 fact sheets, and we calculate projected population estimates and burden for children non-pregnant and pregnant women using the population projection report, Census 2011 data, and Hmis. Next slide, please. This slide shows a snapshot of the data visualizations and tables in the data note for each undernutrition outcome. Here, the pages for stunting have been shown. The comet plots provide the state level trends between Nfhs 4 and 5, while the state level burden maps illustrate burden for each state in thousands. The district level maps include the burden map, which categorizes districts by quartiles of burden, and a map highlighting the top 100 districts with highest burden in purple. We also include a table with the list of the top 100 districts with the highest burden, which includes the name of the district, the state the district belongs to, the burden of the district, and the rank of the district. Next slide, please. Over here, we have a similar snapshot from the data note for anemia among children. As mentioned earlier, we also included anemia among children, non-pregnant, and pregnant women. This can help policymakers prioritize districts for treatment and management of anemia. Next slide, please. Finally, we have included a glossary and detailed methodological notes. We hope that these notes can assist anyone who wishes to replicate this analysis. And finally, we are working on a composite index for undernutrition prevalence and burden to help identify which districts have high prevalence or burden of multiple forms of undernutrition. Thank you. And now I will be handing over to Isha for the virtual launch.
Thank you, Anjali, Nishmeet, and Soira. I would like to take this opportunity to launch as well as to take you through how you can find these products on our website. So I'll quickly share my screen. So if you go on our POSHAN website and if you go to publication and resources, I hope everybody can see my screen, just checking. If you go to publication and resources, and if you go by geography, it will take you to a page called states and districts. When you click on the page called states and districts and scroll down, you will find the list of all the states, 36 states and UTs on this page. You can click on any of the state name, and that page will take you to the state page where you will have, in the chronological order, all the products that we have for that state. For example, in 2022, what we are releasing right now is our state nutrition profile for Uttar Pradesh. When you click on it, it takes you to the state nutrition profile for Uttar Pradesh, and you can download it, you can view it, and you can share with others. Similarly, if you want to go to the district nutrition profiles, you again go to the same page and scroll down, and I will just, to virtually launch, click on one of the district nutrition profiles that is for Agra. And here you can see we also have the previous version of district nutrition profiles which we used, which were made with the Nfhs 4 data already here in English and Hindi. And as of now, we have the district nutrition profiles with the Nfhs 4 and Nfhs 5 data in English. So you click on English and then you get the downloadable profile. So once you go to our state page, you will get all the material that is related to that particular state. Yeah, I hope you can see that. And all these materials are downloadable. So you can click here and download. And finally, I would just like to also launch and show all of you the data node on 100 high burden districts. So for a particular data node, which is at national level and not belongs to a particular state, you just go by type. And these are the types of the products that we have. You click on the data node, and you will find the first data node because it is launched today. You will find the 100 high burden districts of undernutrition among children. You can click on the picture or you can click on the link to get access to the data node, which is again available for download. So I request all of you to kindly go through our website, explore the POSHAN website. The POSHAN website is actually more than a website, it's a repository of our products and repository of all the data and research products, which you will find under publications by type or publications by geography. So with that, I would like to congratulate the entire team for working on these state nutrition profiles, district nutrition profiles, and the top 100 high burden undernutrition data node. And I would also like to specially mention here that the idea of these top 100 high burden undernutrition data node was of Dr. Sarwal, who's our next speaker. So I would like to quickly take this opportunity to introduce Dr. Sarwal and then hand it over to him. So Dr. Rakesh Sarwal is a senior IAS officer and holds a doctorate degree in public health from Johns Hopkins University, USA. He has served in the social sector in various capacities in the northeastern state of Tripura and the government of India. As Advisor Health Planning Commission, he was instrumental in preparing the 12th fifth-year plan. Welcome, Dr. Sarwal, and over to you for your remarks on the use of these knowledge products and what are the further research questions that you would like people like us working on data to dwell deep in. Over to you, Dr.
Thank you, Isha. The representatives from IFPRI, led by Punnama Menon, and the brilliant team of young researchers who presented before me. The representatives from Indian Institute of Population Studies, Dr. S.K. Singh, who made an excellent presentation on the quality of the data, reassuring any apprehensions that we may have. Members from the UNICEF, IEG, and other research colleagues. I think it's a very important occasion today when we have assembled today to launch the digested product from the findings of Nfhs 5, where it compares the trends as compared to the earlier two rounds and gives the very attractive and easily presentable, readable profiles for the districts, the state, and the country. I'll start by narrating an incident here in Neethi a few days back. I got a call from my colleague, the principal secretary planning in a state of the country, and he said, I don't find the state profile for my state. I see it for the neighboring state and it's not available for my state. I see your name, I see Neethi associated with this. Why is my state profile is not available? My minister is sitting next to me and we would plan for the prioritization and we would like to have our profile. So I immediately called up my team and the profile of that state was not released in the first round. We collected an advanced copy of that and I shared with him and he was very grateful for that. So that is the level of use and the level of appreciation for this work, for the profile work, for the simple reason that in very few pages, in 4 pages, the district nutrition profile, and in just 12 pages, the state nutrition profile conveys everything which is required to know the status, understand why it is like that, and what can be done. I think it's an excellent tool, and I would like to congratulate IFPRI and other partners who have taken this lead and anchored it and the entire team who have worked diligently to bring it out. I'm sure it will be extremely useful in the purpose for which the entire survey was done, which is really to target and change the situation for the better. The purpose of all management measuring well so that you can manage well. Now that the measurement part has been done, now the management part needs to be taken up. And I think in this task, the theme, the underlying data, the underlying trends, the underlying reasons, immediate underlying determinants, and the practices and the service delivery beautifully brought out in these profiles will be of extreme help to our district magistrates and the nutrition team at the state level in not only targeting the population where these indicators are poorly performing, but also the dimension of health, which needs to be addressed. As we have seen, a large proportion, 80–90% of our districts are high burden. And even when the wasting stunting levels are low, the levels of obesity and other metabolic diseases is on the rise. So there is no resting phase here. Every district needs to prioritize its high burden areas, the high burden conditions, and tailor the conditions, tailor these interventions in a way that these problems are addressed. I think in this task, these nutrition profiles would be very, very relevant. I would like to highlight here that these numbers are just averages, and they hide a huge amount of variance in at the population level. The condition of the lower socioeconomic segments of the families, population, the scheduled castes, the scheduled tribes. And while the averages are good enough, but as the primary unit level data comes out, it will be important to understand who are the worst off among the entire population in each of these indicators, so that the targeting can be tailored to that target group, that population, whether it is economic or social detriment. I think it's also important that while we have these baseline indicators in the first and the second phase, to also use the running data, the routine monitoring systems to know how we are doing and not just wait for the sixth round of the Nfhs. So in that regard, I think it's a challenge before our research community, that how to effectively utilize the HMIS data, the POSHAN tracker data, and other reports, regular reports which are coming in our system, to know whether the change, whether the needle is moving in the right direction as the interventions are taking place, as we are targeting the right population for the right conditions. So it's a huge step today in the release of these nutrition profiles. I think it sets the stage for further research, further application of mind, and above all, a focused implementation in order to reverse the trends and the conditions which have worsened, and continue the good practices, the enormous amount of good practices and the positive news which is coming out, to continue those practices in future. So thank you very much, IFPRI, for bringing it out and for getting me over here. Thank you.
Thank you so much, Dr. Sarwal, for giving your time. I know you have additional responsibilities now, and then also you agreed to be with us for this webinar. I hope you can stay for the rest of the event, because we'll have a panel discussion followed by a round of question and answers. We have around 29 questions in the Q&A box. So without wasting any time, I would like to invite Punnama, who will be moderating this panel discussion. And on our panel, we have Dr. S.K. Singh. Dr. S.K. Singh has already spoken in the beginning of the webinar, who's a professor from Department of Mathematical Demography and Statistics, International Institute for Population Sciences. We have Mr. Robert Johnson, who's a nutritional specialist, knowledge management with UNICEF India. We have Dr. William Jo, who's an assistant professor at the Population Research Center, Institute of Economic Growth. And we have Dr. Neena Bhatia, who's a technical senior specialist with Niti Aayog. Can I request all of you, all the panelists, to kindly switch on your cameras so we can see you as you talk. Over to you, Punnama.
Thank you. Thank you so much, Isha. And, once again, let me congratulate our entire team of collaborators, senior researchers, analysts, and everyone else who's been working very, very hard on putting together these many different data products over the last few months. I have two questions for our panelists today. And so let me kick off with the first question. So the question that I have for us is, as I mentioned earlier in my introduction, the idea behind data and knowledge products like this is to inspire use and is to sort of really engage people around the use of these to, to really shape what happens. So I'm wondering if I can sort of call on each of you to reflect on that. Can you sort of really think about, what do you see that lies ahead in terms of data use? How can these profiles and products that we have all developed together be used across the different states in India, the different districts in India? And feel free to reflect on your experiences with this in the past. I know, for example, William, you've been very involved in supporting data use in the context of anemia. I know, Robert, you've been very involved in supporting data use in the context of severe and acute malnutrition. Dr. Nina, you've been involved in this, more generally in the context of POSHAN Abhiyan. So if you could reflect on this, what are some insights? What should we be looking for, as we look forward? So maybe let me call on you first, William, and then we'll take it from there, maybe about 3 minutes or so each, and then I have another question for each of us after that. Thank you.
Yeah, thank you, Punnama. So shall I go first? Yeah, thank you again. Let me begin by congratulating you and the entire team of collaborators for this tremendous effort. I think the statistics that we have in the district profile, it's really a wealth of information for anybody who is interested in the field of population health and nutrition in India. So it's very detailed, very thought out process. And as part of this process, we know that we have discussed this so many times about what should be actually going into these fact sheets that will help people to understand the situation. So once again, congratulations for this gigantic effort to bring out these fact sheets. And today, finally, we are at this stage where we are opening up all the information that we have analyzed through these fact sheets for public consumption. So it's a great moment. I think that now, since we have developed this, it's important that it is used very widely. And my main focus here will be to distinguish use across policy making bodies as well as from an academic and research perspective. Now, in general, people would like to know what are the different estimates for different indicators, which is very straightforward, I think, application of our fact sheets. It's a great opportunity for anyone to quickly review the situation across states and across districts. But I think from a policy point of view, there has to be greater kind of congruity between the Nfhs data and the administrative statistics. Now, Nfhs data in a way has started this momentum that we are looking at outcome indicators across different domains. And that policymakers, they have taken note of saying that we are not doing well in certain indicators, or we are performing better in certain indicators, or certain states and districts are doing much better than say our state or our district. So that Nfhs has generated this momentum in the last 2 to 3 decades. Now we have to take it further to lower levels like the district level and maybe even further sub-district level. Now this is where I think the fact sheets can be very handy. I will give you 1 or 2 examples. For example, I'm closely working with the Anemia Mukt Bharat program, and we find that the Nfhs gives us information on IFA tablet consumption among pregnant women. On the other hand, the administrative statistics, the health coverage statistics through health management information system, it provides us information about how much tablets have been distributed. Now we have on one hand the supply side information and on the other side the household information. So, but these data, are they talking to each other? What kind of insights a district administrator can get by comparing Nfhs data and HMIS? So HMIS clearly shows that the levels have improved in terms of coverage, and Nfhs also agrees that the levels have improved in terms of consumption. So they are in the same direction, which is something like a very positive news that both are speaking in the same terms and saying the same, conveying the same information about the program. But the gap is the program has done exceedingly well in terms of the coverage distribution, but the demand side has not picked up. So these fact sheets will provide us an insight about where there is greater gap in terms of our distribution and the intake of tablets among the beneficiaries. What can be the possible reasons? That can be easily explored by looking at this. And even on the supply side, the administrator can check whether the coverage data itself is of high quality or not. So these kind of gaps can be very easily monitored if we are looking at the data. Another important application, I think, is that the HMIS data, which is very good in terms of its scope and coverage, because it provides us monthly information and like sub-district level information, and Nfhs provides us information at the district levels. But what happens is sometimes because of sampling limitations, Nfhs may not be able to provide us district estimates for all the indicators, which is a kind of an issue for some of the districts, especially low fertility districts. Now we can take this and compare that with the HMIS information so that like both are in the same direction and both are providing some consistent insights. I will not urge very strongly about the magnitude being the same, but at least in terms of the level and the direction, which can be very easily like verified using Nfhs fact sheets as well as looking at the administrative statistics. So I think there is like great deal of potential where we are linking Nfhs data to program data for like monitoring, review, and course correction. Finally, I think one more thing here I would just like to add that Nfhs is now having that course of addressing more of the programmatic indicators. Like initially, most of these were standard indicators in the literature, but I think with expansion of scope of Nfhs, there is now more insights coming on the programmatic indicators aspect, which is also a good thing that the district fact sheet will help the like policy making to understand their performance. And a whole range of program. I'm just talking about population health and nutrition, but there are certain other related sectors for which also this district fact sheet can provide very good information. So I think there's tremendous potential for using this, and I hope like others would also contribute. Thanks, Punnama.
Thank you so much, William. I think, one of the things that you're raising is also related to, what eventually will end up being some, also some challenges and complications around data reconciliation of insights and other such things. But, also, and maybe you can come back to this later on, what role do we as researchers and, sort of supporters of data-informed conversations, what roles can we play, to also help with some of that, reconciliation and strengthening understanding. So Robert, let me come to you, for your reflections on, data use and your thoughts on how we might use some of these profiles looking forward. Thanks.
Great, thank you. Yes, no, first, great congratulations to the beautiful work that is being released today. And the way that you've managed to pull all the different partners together for this. It's a great step forward, and we really appreciate it. We love to see how you have really made these knowledge products of nutrition data into living, breathing material that that will be used in the hands of the district managers, and you're responding to their needs and their wishes about how the data can be presented and be put to use. I've had the great opportunity to work with everybody on these panels and this panel today, and I just want to say my appreciation for having the chance to work with everyone. I love the presentation of SK Singh, Professor Singh, about tools and methods and how these methods are improving beyond what we could imagine 10 years ago, and so that these gives us so much more opportunity to collect data and to open the data collection opportunities across the states. And working with Professor Unisa at IFPRI-POSHAN, we were able to put together a CS Pro tool for the data collection and analysis of anthropometric standardization. But we want to see how this is going to be put to use in these next rounds and every opportunity where we collect anthropometry data. So I love to see the tools and the methods improving over time. We see in the work of Institute of Health Metrics and Evaluation and Public Health Foundation of India that data does not have to be collected at all at one point in time to be able to put together into a database to analyze issues such as they've done in the global burden of disease. So we do as much as, and when and where possible, we need to take advantage of data collection opportunities to respond to the frequency of data needs. And this goes to my point that we as a network of nutrition collaborators, we need to move to respond to the state's needs for data. And we can only encourage them to use the data more and more frequently when we respond to their exact needs and their exact requests. So as Professor William Joe has said, there's so much we can do with the available data, but we need to gain that ownership and respect and engagement from our state and district level colleagues by responding more closely to their needs. And that's what I think this process is doing, and that's what I appreciate so much of it. Thank you very much.
Wonderful, thank you. And Dr. Singh, if you're there, I wonder if you can also reflect on this idea and this issue of data use and how you see these profiles and products which are based really at this point just on the initial set of fact sheets data being sort of used for strategy and assessment. I can't see Dr. Singh there. So that's, maybe we'll just wait for him to come back. And I know we were expecting Dr. Meena Bhatia from MITI here as well, but she was called into an urgent meeting. So let me maybe move on to the second question, and then we'll move on. We'll open it up for Q&A because I see a lot of questions and a few hands up as well. So maybe both, to you, Robert, and to you, William, what's missing for you from a data perspective when you look at these profiles? I mean, they're based on, of course, the Nfhs, but, many of us who work on nutrition probably would like to see a few other things available for these districts and for these states. So what's missing for you? What's on your data wish list, for example? What else would you like to see? I know I have my wish list. I'll come in at the end on that, but what's on your wish list? William?
Yeah, Robert, maybe you want to go first?
Okay, sure. Yeah, let's Robert go first.
Sure. What's on my data wish list is that's a great question. First of all, yeah, I'd love to see how comprehensive this effort has been, and so it's much stronger than former efforts, and so I think it responds to a lot of needs, especially with the beautiful graph across the continuum of care. What I see missing is our perpetual headache, is that we're not engaging strong enough on women's nutrition, and we need a greater attention to adolescent nutrition and moving into women's nutrition, and this means data around diets and food consumption behaviors, and all the aspects that really can impact adolescent and women's nutrition, and then looking at how does this translate into impacts in gestational weight gain. We're not having free-flowing information on gestational weight gain, and we should have that information at our fingertips to be able to more aggressively address the needs of women. And how does this translate into low birth weight? Low birth weight is not a be-all and end-all indicator of the nutrition of the maternal child diet, but it is something that we can work with, and we need to take advantage of those data as much as possible. So those are the big pieces that I see missing from the current data framework. Over.
Great, thank you. Definitely a lot of commonalities there, and I think what we're looking for. William, what about you? What's on your wish list? What else would you like to see at the district level or at the state level?
Yeah, thank you, Punnama. Yeah, of course, like Robert has highlighted some of the like gaps, I think, which are important. And I think the CNNS had addressed some of those concerns, but I think we need more regular, frequent information on those indicators. So like given those challenges, I think NFHS itself finds itself like a place where everybody keeps on demanding that keep on adding more and more indicators. And I'm not sure how much like they are able to accommodate things. So this is a big challenge for NFHS, and some of the variables are of course not much used, whereas like certain other important indicators which we believe should be there are not still present in those surveys. So it's a big trade-off, and I think two important aspects will be they can be a little more ambitious, if not in terms of sampling design, but at least in terms of going sub-district, because at the district level, there is greater focus to understand the intra-district disparities. Maybe next time, Punnama, hopefully you will do the sub-district one as a fact sheet where the districts can like, they want to know what are the gaps within that. So that is a big area, and they are looking to other statistics like the service statistics for those indicators. So it may be a challenging thing from a survey point of view, but maybe through analysis or through indirect estimation, something can be done if some help can be provided through the NFHS in terms of codes and identification strategies. Other thing I feel which can be much more important for NFHS is to it's more about the program statistics being very consistent with the NFHS statistics. I think, and here there is a greater role of the research community to keep that like validation or make this marriage happen, because these estimates often diverge a lot. Maybe you can compare ICDS based undernutrition indicators with the NFHS one, but why the gaps are there and which is correct kind of. So often we go with the NFHS estimates, but this is a good opportunity where I think more work can be done. In terms of the way NFHS indicators, I think there are a lot of indicators which have good programmatic connotations, but organizing them in a way which directly gives inputs for the programs. For example, the process indicators, the outcome indicators, we often have certain outcome indicators from NFHS, but we may not be able to review the program from an NFHS lens. So that is something I think if say, I'm not sure NFHS must be doing this. They must be getting feedback from all the program division about the requirements for indicators, and whether how much they are able to accommodate that itself is a challenging thing. But I think if some logical way of allowing program reviews through NFHS can be done with like a key performance indicators approach, that itself can be a good strategy to like further strengthen the connect between NFHS and direct policy reviews. So these are like some of the areas I think where a lot of scope is there for NFHS to like further go ahead. So one is the sub-district level, one is to have much more focus on process indicators, like not only consumption and anemia prevalence, but whether they received anemia tablets or not and how many. So these simple things can connect it very much closely with the government programs. And finally, it's an important task that we get more consistent estimates from NFHS and other government statistics. So yeah, difficult task, but I think it's way forward and we can do it.
Yeah, thank you both so much for those reflections. So, what I heard from you is, both a set of sort of bodies of data that are available to people at the district on some key missing topical areas. Robert, I think you raised some very important points there on, on the need for data on diets and diet quality. And to that, personally, I would add that it's really critical for us to understand things such as food security and poverty, which are really missing, utterly missing in our data landscape today. There is really no way, to know in any of these districts, how many people are poor, how many of those households are food insecure, because we know that those profoundly affect a range of different malnutrition outcomes, whether it's, undernutrition, anemia and other such things. So personally, on my wish list, whether it comes from the NFHS or not, I would really love for us to be able to have data on diets, poverty, and food security in these types of district profiles. There's really nothing to hold us back from using multiple data sources in the district profiles. And in our 2016 profiles and even the earlier sets, we definitely did draw down on data from, for example, the NSSO survey, but that survey is too old at this point to make poverty estimates or calorie undernourishment or food security estimates. So I think for me this is a big missing. It's a gap in the profiles that is actually coming from a gap in our national data systems around these topics. So if anyone else has ideas on how can we sort of gather and present the kind of data that would be helpful in getting these things, and then also in perhaps deploying the available administrative data sources, William, to say, okay, can we construct, a snapshot at least of process indicators or of a few critical indicators at the even sub-district level for some of these districts. I think there's work to be done in next iterations or in supplements to these district nutrition profiles. I know that there are other groups also who are looking to consolidate data at these multiple geographic levels, and I really want to to acknowledge that. And then, Robert, the other thing that you of course mentioned is that there are missing demographics and population groups, on whom and for whom having data would be really very useful. And a few days ago, 2 days ago, we attended the big sort of event on the state of adolescents and young people in UP and Bihar coming from the Udaya data sets. And it was just a really tremendous reminder of how powerful it is when you have data on those missing population groups. I think the work that the CNNS did was also so important in helping us see what was happening, at least one snapshot in time for adolescents and young people, but that was available for the states, and the Udaya too was representative at the state level. But if we want action that is on the ground, then I think we also really need to think about how can we know more about these things for for a group that is in a sense the future of of this country and really of the world. So again, let me thank both of you for your really thoughtful remarks and responses there. I would like to invite back our other speakers, and feel free, William and Robert, to also stay because we'll now move into the Q&A. I have 37 questions in the Q&A box. This is going to be very, very challenging. I also understand that Dr. S.K. Singh has not been able to join us back because of a technical difficulty, but I'd like to invite Fung, Nishmi, Soira, Anita, if you could all also come back on screen so we can move into the Q&As. So let me first start with a set of questions for Fung. There is a whole a cluster of questions that are asking about the definition of public health burden and how that is defined. So if you don't mind perhaps reflecting on or sharing insights on that. How do we define public health burden in the context of these different profiles?
Yeah, so thank you for the question. I think that in terms of consider that is a public health burden, we use a WHO definition for stunting, wasting, and underweight. And then for anemia, we also use a WHO indicator. So that one mainly apply for the percent, like what's that district in what level of percent. So I already sent the link from the WHO in the web. Just example, if the stunting, if between 20 to 30% is considered high, if that district, and more than 30% is considered very high based on the public health significant cutoff. For wasting, between 10 to 15% considered high, and more than 15% considered very high. And then they also have a overweight, but we don't have a much overweight. So if 10 to 15% considered high and more than 15% considered very high. For anemia, we use the same WHO cutoff that we can share the definition later on. For the number, we don't have a cutoff like what number is considered high or what number is considered low, because the number basically depend on the population of that one. So we're more likely with the burden number, we more likely compare relatively one state with other state, but we don't have a cutoff. The cutoff mainly based on WHO on the percent. Thank you. Yeah.
Great, thank you, Fung. And if you have access to that paper on the prevalence cutoffs, etc. Maybe we can also post that in the chat, or we can share that later. Unfortunately, Dr. Singh is not here, but William, I'm going to put you on spot for another set of questions. So I have questions here asked by Digvijay, Shinde, and maybe Robert, you could also reflect on that. And this is really that question of, what happens when you go down to either the state level or the district level and you're working and meeting with officials who see a certain set of data on the Nfhs profiles, they see a certain other set of data on from their HMIS or administrative data sources. How has it worked for you to support people in reconciling insights from these two data sources? William, would you like to come in on that? Because I know you've been supporting a lot of work on anemia there.
Yeah, sorry, Punnama, some disturbance here. So, maybe can I get the question again, please?
Yeah, sure. So the questions, there's a few questions in the chat about this issue of reconciling of data. How has that, how can we actually support people to do that? I have a response on, for example, the difference between the use of either ICDS CAS previously or POSHAN tracker data versus Nfhs data on the burden of undernutrition. But I was wondering if you could reflect briefly on that as well. And Robert, maybe you can comment too on this.
Yeah, I think this is a very challenging area, like how to improve the service coverage statistics. And often we find that they have like two kinds of focus. They are skewed, like they have very high coverage or they don't have any kind of information there. So either a lot of missing data or like a very good coverage kind of statistics. So that world is something very different than the survey world where we find estimates from the households. Now the challenges that they have are many in terms of their focus on what indicators should be prioritized for reporting, their frequency and their reviews. So I think the best strategy is overall, I still feel that these statistics are improving in the last 10-15 years, which is like, I think a good trend. We will find that like a lot of HMIS data is now getting reviewed at various levels. And with like constant reviews, it is improving in terms of its quality. So without like a focus of district program managers and senior officials about how the data of their program is behaving, we cannot get that data corrected. So that itself is the major challenge. And given my experience, I think that these things are improving over the last kind of 5-10 years period. Initially, the quality was really very bad. Even now also, I think many statistics have very poor reporting standards in terms of coverage, in terms of consistency of reporting. But I think we should emphasize that there has to be like good triangulation exercises based on say Nfhs comparison with the indicators from the service data, say HMIS indicators. Like we are doing for coverage statistics for anemia program, the prevalence statistics on anemia. We find that in some districts, they are like more or less consistent, but there are a lot of districts where it varies. But the best way forward is to actually make these comparisons on a regular basis and try and share these findings at the review bodies where they actually look at the HMIS data carefully or the ICDS CAS data more carefully. So it's only with a constant appeal to them about the statistics that they are owning, they can improve this. Of course, like other possibilities that we have to invest more in terms of this data collection apparatus itself, which I think is really weak. We rely more on the frontline workers for reporting of this information, which sometimes like depends upon their own capacity, their own time constraints. And this leads to sometimes data quality issues about the indicators which are reported and the frequency in which they are reported. So more focus is needed from a system point of view this data. But I think if you will look at some selected indicators, you will find that the data is really good and it's improving. Because Nfhs, I think probably should be used mainly to look at the estimates, the levels, and this service statistics will provide us an idea about where we are moving in terms of the direction, in terms of improvement. So both has to be used simultaneously, and we focus more on like the coverage data by creating more pressure in terms of validation checks, in terms of other consistency parameters that we can bring up. So more work for the research community. Yeah. Thanks.
Thank you so much for that. Robert, would you like to come in on that? And then I'm going to call on Anjali after that to speak a little bit about HMIS data quality work. There's several questions on that as well.
Yes, very quickly. Yeah, these issues have come up. We were working with the Chhattisgarh government on the Vajan Tiohar. They've done an incredible effort to go out and collect data on over 1 million children on heights and weights and age and bilateral edema. And then taking these back and making comparisons to the available data and trying to make sense out of what they have in their state level collected data versus comparing to the surveys. And we had to go in depth into explaining the sampling and explaining the difference in the training and tools and reporting and how that was worked. But they did a tremendous effort, and going through those data, you find, I think out of the 1 million cases, we had about 300 duplicate data points. So the quality in that sense was really strong. And so we need to support these states in when they're doing their own data collection efforts to try to bring on, what are the quality control mechanisms that we can add in as we go along to ensure that we do have better comparable data. And this process of assembling the data largely on a quarterly basis and presenting it back to decision makers has been something that's been a real priority for us in the past 5 years, and bringing up these meetings that we call C-square IQ meetings, where we review the coverage, the coverage, the continuity, the intensity, and the quality of data, and bringing up these points that William had mentioned. How do we look more at the implementation process and to try to ensure that we are delivering the actual services that we're trying to, and brings up another point of where we need more and better information, and that is within the Jan Andolan for nutrition, that we have tremendous amount of efforts that are going on to deliver community-based events for behavior change around infant diets. And we have a tremendous amount of efforts. We have data collection tools in operations, but we need more information about how the information is being communicated, what is being interpreted, adopted, implemented, and how that translates into improved dietary diversity and food frequency of feedings for children. So these are just some points that I think we need to continue to address. Over.
Thanks, Robert. So Anjali, there are a few questions. I'm finding it interesting that, of course, we've presented profiles based on the Nfhs, but a lot of questions that are coming up are also related to, issues of the HMIS. So I know you've been working with a team of researchers both at IFPRI and, Icds and other qualities. I was wondering if you could just say a little bit about what you've been doing there. And then I'll come to you after this call.
Okay, so so as Punnama, you said that we have been working with Icds on several data quality checks using the HMIS data. So we evaluated HMIS data between 2019 to 2021, month-wise, all India. And we did 4 kind of checks. So we looked at over-reporting. That is, what we did was that we first computed some indicators. For example, the percentage of women who received IFA. So that is the number of women who received IFA divided by the total number of women who were registered for ANC. So we computed several of these indicators to see whether there was any over-reporting in the indicators or not. And we found that in several cases, the percentage was greater than 100%, indicating that there was like a lot of over-reporting in several indicators. I'll share the findings later on. First, I'll discuss the kind of checks we did. So the first is over-reporting, and we also looked at the missing data, whether there was any missing information in the HMIS data set or not. And third, we looked at, the outliers. So whether, the values that are available in the HMIS, whether, like how much away they are, like the number of standard deviations they are away from the mean values, whether there are any outliers in the data values or not. And then we also looked at the duplicates. So like over time, if there is any particular data value that was repeated, say across months for a certain indicator. So we also evaluated that. And for some indicators like home deliveries and infant deaths, we found a lot of outliers, but it was not there like for all the indicators, but just for some specific indicators, like, as I said, home deliveries and institutional deliveries, live births, we found a lot of outliers there. Over-reporting was a major issue specifically for the early childhood indicators. For example, full immunization, IFA received, albendazole, and even the the postnatal care indicators and those kind of indicators, we found more than 50% over-reporting, which is huge. So what we have heard from Hmis team is that they do like several rounds of checks to ensure that the data quality is fine. But despite that, we found this kind of an issue in the data set. Then missing values were very few. We did not find like very high missing values.
Anjali, sorry, we will organize a separate event for people to talk through the findings of this. I think I just wanted you to quickly describe what you're doing. Thank you for that. With Anjali has been working with a team from ID Insight and others to look quite carefully at the quality of the Hmis data for some of the nutrition indicators. And I think given the interest that we are hearing from all the different partners here, I think we absolutely need to arrange a next webinar to look at that.
Sure. So I would just like to highlight that over-reporting is like a very important issue in the Hmis data set, and that was kind of big finding from our study. So that's all.
Great, thank you. And I think the points that you're raising also relate to a few questions that are in the Q&A about why we had not, for example, used either ICDS-CAS or POSHAN tracker data or anything like that for reporting on some of the outcomes that we see here. And it relates very much to who is the population who is covered by the administrative, the data in the administrative data systems versus who is the population that is covered in a survey like the Nfhs. And I think that is really critical for us to remember. The Nfhs is a population-wide survey. Many of the people it covers and samples everybody across. It is intended to, the sampling covers people who use public services like the ICDS and public health services, but it also includes a lot of people who don't use public services. And so the ICDS-CAS or POSHAN tracker or even the Hmis data sets often reflect a population subgroup, in some states fairly large numbers, of course, who use public services. And so it's not representative of the whole district, whereas the Nfhs is representative of the whole district. This is really, really important for us to remember as we look at that. So Phil, I would like to ask you to come in on a couple of questions that are here about anemia. There has been research in India or suggestions that different cutoffs maybe should be used for anemia. So I was wondering if you can just reflect on how we might be looking to work on that as we look forward. I mean, of course, these profiles are not based on the unit level data, but if you can just reflect on some of that. And then I think there was also an additional question that you wanted to answer live. So maybe you can get to that also. You're on mute, Phil.
Hi, yes, I think, I clicked the wrong buttons. I tried to type, but I click online and I don't know how I can fix that. So anyway, I think the anemia is really a hot topic that everyone work on nutrition really concerned about the situation in India. Why we did a lot of work, right? But why is the prevalence is still high? So I kind of very agree with you that there's a cutoff that proposed for India, and that is our next step that we will consider start to work with IFPRI to see like we compare the one with the traditional cutoff with the new cutoff to see how it look like with the anemia prevalent in India. But remember that if we only look at the cutoff, then the cutoff will apply for both Nfhs 4 and 5. And if we either lower cutoff or higher cutoff, the prevalence, the trend over time shouldn't change. So that's still worrisome for us, like in the nutrition community, what should we do? Another way we can think is anemia have a lot of etiology behind that. It's not only iron, but it's also vitamin B12, it's also folic acid, it also diet, and then hookworm or other kind of worm, and then also kind of, we look at the paper by CNS group that has some like hemoglobinopathy. So I think there's a lot of things that we need to consider around anemia beyond the iron folic acid supplementation, even with the fortification right now, because supplementation can go to some target of a population like pregnant women, but we have a more than half of non-pregnant women who are also anemic. So what should we do about that? The fortification can reach more people, but again, it's also less likely to go to the remote area also. So that is some question that we are considering working on that, seeing that the prevalence using different cutoff, how it look like, and also look more on the etiology, and then think more carefully about all the strategy around that, how we can move things forward with the current policy program, but also more innovation way. Yeah, thank you.
Great. Thank you so much, Fong. Dr. Lakshmaya, I see you're in the audience and you have raised your hand. So I have sort of given you the option to unmute if you would like to come in to ask your question or make your comment live. If you're there, Dr. Lakshmaya. All right, I'm not sure. Well, while we're waiting for Dr. Lakshmaya, I see there's a whole cluster of comments here also on, why, right? And many of you have asked, why is antenatal care down in Kerala and stunting up? Why has dietary diversity or minimum adequate diet improved in Orissa despite the data from being collected, around the after the pandemic, etc. So, I just want to be very clear here. Our intent right now and in this in the launch of these profiles is not to answer those why questions. I think it is precisely to raise the kind of questions that people are raising as they look at the data. And what we hope is that many, many, many researchers and investigators across India and researchers in other parts of the world who are interested in and collaborating with other researchers in India will look at some of these profiles and ask those deep why questions, and that you will invest in doing the research to answer those questions using additional research methods. I think there's only so much that one can answer about why from data sources like the Nfhs, and I want to sort of point all of you to some of the analyses that our team has also been doing on success cases in malnutrition, where we've used and deployed a whole range of different methods to answer why questions. And so, Saira, I was wondering if, very briefly, because I know you're working on some why questions for, why are we seeing the kind of change that we have seen, for example, in states like Bihar. I don't want you to maybe give us any of the findings because I know we're still working on that, but if you can say a little bit about the methods, what are the methods we're using to answer these why questions? Thanks.
Thank you, Punnama. So as Punnama mentioned, we are working on a state level case study on Bihar, looking because Bihar between Nfhs 3 and 4, we have seen a continuous reduction in stunting. So the methods we are primarily using, just to briefly touch upon them, are we are doing a desk review. Then we're also conducting stakeholder interviews with development partners, academics, and government officials. And we are also doing some data analysis using the Nfhs data. And this involves doing a regression decomposition analysis as well to understand which factors are contributing to the change in stunting. Then in the district level case studies, we are working on a case study looking at two districts in Bihar in more focus and more detail. So this would also then involve stakeholder interviews with the district level officials in those districts. And we are also working on district level case studies related to anemia for districts in Uttar Pradesh and Odisha, because we have seen in these states that there's very high inter-district variability when it comes to anemia performance across the three groups we are considering.
Great. Thank you so much, Sarah. I mean, those are long and involved studies. So, I think, again, I just want to emphasize for everyone asking why questions that the investigation of the why and the how takes time, it takes effort, it takes us to look at the literature, to talk to people, to look at the data more deeply, to do additional empirical analyses, to bring in data from other sources. We take that work very seriously. And so, we will be doing much more why work as we look forward as well. But we also encourage those of you who are working on this to, to let us know about your work. So I know we're almost at time. I'm just going to check again if Dr. Lakshmaya was able to unmute and would like to say anything. There are a lot of questions in the chat box. Again, I want to thank everyone for showing your interest in raising those questions. We have tried to answer some of them live here today. We've tried to answer, some of them in the chat boxes there as well. There is one question Dr. Lakshmaya asked that, maybe I will try to respond to. So he asks if, is there a blueprint of actionable strategies to implement in the high burden, top 100 type of districts? And that as the National Institute of Nutrition, they're also being asked how to, take actions. And so he's wondering about models, et cetera. And so, I guess my response to that is I don't think at this point we're looking at, new models, new approaches, et cetera. What we're really looking at is, how in those high burden districts do you make sure that the programs, the policies, and the strategies that are already available in India's policy framework actually reach those populations that need. I think to me it is amply clear from the work that our team has done and that this incredible group of collaborators has done to look at, district by district, state by state, the reach of interventions, the state of play of immediate determinants, the state of play of underlying determinants, that there remains a lot of work to be done just on those things. And, we know that in India, we have the policy instruments in place. The reason why you're not reaching coverage, the reason why those underlying determinants or those immediate determinants aren't moving as fast as they should is because some of these policies and strategies and actions aren't reaching fully all those who should be reached. So before we go off trying to find new models and new innovations, actually doing the work at hand to understand why things that are evidence-based are still not reaching those who should be reached, why they're not operating at the kind of quality that they should be operating at. I think these are some really critically important pieces of work for the nutrition community. And of course, I think it's absolutely appalling that we do not have data on the state of food security, on the state of diets, on the state of poverty in each and every one of these districts, because without that, we can't even work on the, on understanding what the challenge looks like on some of those very critical underlying determinants for nutrition. We have 2 minutes left. I want to ask if anybody here would like to do a 30-second intervention before I close with some acknowledgements. 30 seconds, no? Going once, going twice? All right, wonderful. Well, let me, once again, thank you all for joining us today. Firstly, we had an incredible audience. I saw, 185 people at some point on this webinar. I know many people will be downloading and accessing and using these knowledge products. So I want to acknowledge deeply the work that Fung, firstly, you have led as as the leader of the data team at IFPRI to support the team, the analysis team, to work so closely with our collaborators to develop, design, and launch these products. I want to thank the incredible team of analysts across IFPRI, especially Nishmeet, Sarah, and Anjali, each of you who has anchored the production of these different products. And I really want to thank the deep partnership with IEG, IIPS, NITI Aayog, and UNICEF, the intellectual inputs and engagement that you have provided over the course of developing these products has been really tremendous. I want to acknowledge the work of colleagues who have left us before these products were launched. So I really want to acknowledge the work that Manita Jangir did on analyzing data visualization tools and then working on the design, on bringing insights from the analysis of those data visualization tools in India to the design of the district nutrition profiles. We were also aided in the design and the visual design of the district nutrition products profiles by Amit Jena, and that work was all supported by Data Dent, which is a global initiative. And I really also want to thank the POSHAN communications team and IFPRI's communications and public affairs team who have been working behind the scenes to get all the products together, designed, laid out, and moving on to our website. So especially want to thank Isha Saraswat, Vinny Ved, and several more of our colleagues. We will begin on a series of follow-up pieces of work as we look forward. As I mentioned, this is merely a means to an end. If we stopped here, we would not be doing our jobs in terms of helping to make sure these products are well used. We look forward to some of our older collaborations, people who will take forward the use of these. But we also invite from those of you in the audience and those of you who might look at these products online, your thoughts on how can we be innovative around this? How can we create more public engagement around these products? How can we be, creative about how data is used and discussed at every level in this country to create the kind of awareness and change that needs to happen for nutrition? I'm also well aware that there are many other data partners who work on nutrition data, ID Insight, Anuvad Solutions from Harvard, the IIT Mumbai team, the National Institute of Nutrition, the Harvard Geo Insights team. And so I really want to say that, in putting these products out, we are not diminishing or, sort of saying that this is the only product that anyone should use for nutrition. What I would like to see in coming days, weeks, and months is that those of us who are working on the different types of data products out there can also really work together, align, and think about how together we can be stronger in supporting communities of data users across India, whether they be parliamentarians, whether they be district officials, whether they be government, civil society, and other actors. So, I really invite everybody who's here today and those who are not here today to join us as we think about, what does it mean to use data to support programs and policies across India. So with that, we're 2 minutes over, but huge thank you to everyone again. And deep apologies if I missed mentioning, any additional names. We're really, truly grateful for the partnership and the hard work of everyone here. And this is just the beginning. Thank you all.
Thank you, everyone.
Yeah, thank you, Punnama. Thank you, everyone.
Thank you.
Thank you.
Thanks, everyone. Bye.